Yeah, so a place I would like us to start our conversation with is I see that you've been doing a lot around mental health and cancer broadly. So when did that start for you?
It started actually when I was even an undergraduate student. I was very, very interested in the impact of cancer on psychological outcomes. I had a professor who was doing work around that in Turkey. I'm Turkish. And I had a personal interest. I had a lot of cancer in my family. My father died of cancer. So I was very much drawn to that topic. But then I did some work later on. I mean, I did my PhD on genetic mutations for breast cancer, BRCA1 and BRCA2 mutations. Following that, I came to Scotland and I started working more specifically on psycho-oncology, on the domain of particularly fears about cancer coming back. So it goes way back, my interest in cancer and psychology.
That's quite interesting. So, what has been your experience so far researching in this space?
It's, well, cancer being, unfortunately, as common as it is, I think it's an area that deserves a lot of attention. And with the medical advances, thankfully, more and more people live after cancer, after the end of treatment. But the psychological impact of receiving treatment does not end with the treatment. It continues for this group of people we call survivors, cancer survivors. And I think my experience is that the impact of cancer diagnosis and treatment does receive a lot of attention. And maybe in the beginning of this field, it was very limited to certain areas. Maybe we focused mainly on really serious issues like anxiety and depression. But now, thankfully, we're focusing on more and more areas that actually impact on cancer patients. We focus on fatigue. We focus um, on fears about cancer coming back. And these are areas that really deserve our attention because cancer patients tell us that they need support with these issues.
Yes, that's an interesting observation. Then let's look at there are several aspects, there are several sides to studying cancer, and I think cancer is probably polygenic, not just in cause, but in also its impact. It has impact on several aspects of the life of the person affected. So when we look at connecting mental health and cancer. And you've also mentioned the requests and the desires of individuals living with this disease. From a research perspective, how do we directly correlate the cancer with the mental health aspect without overlooking potential confounding factors that may not be mental health related or as a result of cancer?
So let me see if I understand your question, Paul. Are you asking about the relationship about mental health and cancer in terms of cancer coming being diagnosed or after the cancer?
I'm talking about researching the mental
Mm.
health impact of the cancer. Possibly these mental health impacts are not directly due to cancer itself. So how do we handle excluding confounding factors when you are studying these relationships?
Mm. Oh, that's a really interesting question because we bring a lot of our experience and a lot of factors that might be dispositional, right, to the cancer experience. Our normal reaction to threats, health threats, um, our normal reaction to life events, whether it is with anxiety or not, may definitely impact on how we respond to a cancer diagnosis. Uh, Irrespective of how we normally respond to events, we still see that something like cancer diagnosis can create a lot of psychological distress. And I should add that we often focus on those people who receive the diagnosis. But there is a bigger picture here. Often, this is something that affects the whole network, whole family, the friends, those loved ones who are also worried about what is happening for their loved one. So I guess it's a very complicated picture. There's a lot of what we would call dyadic relationships as well between the patient and also those around them. Now, going back to your question, how do we account for other factors? That does require often comprehensive studies that look at it, not only sort of what in that moment the person feels, what we might call state level of anxieties, but also what do the individuals bring to the situation? What are their trait-like symptoms? How do they normally respond to anxiety? It might also be very, very important to look at sociodemographic factors as well. What role their sociodemographic characteristics play. So I think it needs comprehensive studies and also needs longitudinal studies, not one-time cross-sectional studies. Following people over time gives us a much, much better picture that we can tease apart the impact of different factors. Does it answer your question?
Brilliantly, yes. Thank you. I know it's a tricky one, but I really did justice to that question. So let's look at this head and neck cancer study. So give me a background on how these all came together. What was the moment that led to this study?
This particular study goes back a bit. So this study utilized this data set from this head and neck 5000 study that is a well-established clinical study in the United Kingdom. Now, it has been particularly hard to study head and neck cancers. They are not receiving as much attention as some of the other forms of cancer. And the purpose of this study was enabling a very multi-center approach across the UK to recruit as many head and neck cancer patients as possible so that we have a really good data set to work with. And they've been also followed over many, many years to look at not only physical health related factors, clinical factors, but also psychological outcomes. And fear of cancer recurrence was one of the measures that have been included in that study, because we knew from our previous experience that head and neck cancer patients are very prone to experiencing fears about cancer coming back. So it goes way back. That study is a very massive clinical study, clinical patient study. Therefore, we had this data set and we collaborated with researchers in the US and also in the UK to analyze some of that, some of the measures. And we were particularly interested in looking at what are the impacts of anxiety and depression on the development of fears about cancer coming back for these individuals. Now, it is often the case that studies can be quite cross-sectional. We had the advantage of being able to look at over time. And that data set really enabled us to look at it in the first year of receiving head and neck cancer diagnosis.
That's really, really impressive. So let's talk. We'll come back to some nitty fine details of the result of the study, but I'm interested to know how you will summarize the results. What do you think the unique findings that really surprised you coming out of the study?
So we study in psycho-oncology anxiety and depression a lot, and we were particularly interested in how anxiety and depression during the time of diagnosis And also the changes over time in these anxiety and depression symptoms may impact the changes in fears of cancer diagnosis towards the latter part of the first year of diagnosis. So time we measured anxiety and depression at the time of diagnosis, 4 months and 12 months, and fears of cancer recurrence, 4 months and 12 months. We wanted to see how anxiety and depression basically at baseline and also in terms of changes impact on fears about cancer coming back. What we've seen is that anxiety at the time of diagnosis, but also the anxiety that increases from baseline, from the diagnosis to 4 months, they were both positively associated with increases in fears of cancer coming back from 4 to 12 months, latter period of the first year. That we expected because we already knew that anxiety and fears about cancer coming back are very much related to each other. We did not see the same pattern with depression. So that was a bit surprising.
Very surprising. Were you able to figure out why?
Several reasons might be part of it. And I think one of the important things that we acknowledge is that, well, first of all, let me put it this way. If we look at the literature, it is often the case that the relationship between anxiety and fears about cancer coming back is more strongly related than depression and fears about cancer coming back. So we knew that there's something about anxiety, feeling anxious, and fears of cancer recurrence that is closely linked. We knew that already. But one of the things that we need to bear in mind as well, that there might be an effect because of the measure that we use about depression. It may not capture some of the elements that we know are quite related or quite embedded in fears about cancer coming back. So there might be in depression a very ruminative state, a lot of rumination, but our measure did not include a measure of rumination. We used hospital anxiety and depression scale, but the depression, that subscale of that measure, might not capture some of the elements that we see in fears about cancer coming back. So maybe there's something about also how we measure depression that may need a bit of exploring and unpacking.
Yeah, that's very, very, very interesting. Then I think a couple of probably around 1 year ago, I was with a mental health researcher like you that was talking about some of these gaps that exist in the tools for these mental health assessments. And that also gets very, very interesting when we look at these tools internationally. For instance, the metrics that we are using to determine to test for depression in the UK might be very much different from what depression looks like in other parts of the world, necessitating the need for the localization of these tools to be able to actually be true reflection of what we are looking for from a mental health perspective. So what do you think this says about mental health tools in general, especially when they are also subjected to some of the challenges that we've mentioned in describing and in studying multiple diseases at the same time? That could also be a confounding factor or limitation. Do you see it as a confounding factor or a limitation?
Such a good question, Paul. I mean, this is something that psychologists and especially probably health psychologists really struggle with a lot. We have no shortage of measures for a variety of mental health related issues, multiple measures. None of the measures, and this is in their nature, can be absolutely perfect. What I always say is that I think what we need to do before we want to study a topic and what to select a measure, we really look at the items very, very closely. we are often lulled into thinking that, oh, well, this is a well-established measure. It's been used over and over again, and also the psychometric qualities look good. But what we sometimes see is that even those measures were well established in the literature can sometimes not make sense to a population. And I'm not even saying that from the point of view of like language only. It might be English speaking people, but still they may struggle with really understanding what is it that an item is trying to capture. So I always say, let's look at them carefully, each item. Does it make sense in our context? Can we talk to some of our patient groups and see, does this make sense to you? Can you tell us what they really indicate when you hear a sentence, an item? So I think there's still, even if a measure, as I said, is well established in literature, I think we need to do a lot of work to make sure that the groups that we are trying to recruit from, our patient groups, really are able to understand those items. And we're not lulled into thinking that they're good measures and we should just include them in our battery of measures. Does that answer your question, Paul?
Oh yes, oh yes, it does. It does. Thank you. So there's something that I also want to. I'm curious to know from your perspective, especially based on this research, is looking at your results. What if you have a magic wand and you have the power to make things happen anyhow you want it? What would you like to see happen based on the results of this study?
Excellent question. What I would love to see is that paying attention early on at the time of diagnosis, in the initial stages of that really difficult period where anxiety is often really high, is really paying attention to those anxious feelings of patients. Because if they are addressed, if they are monitored, if there's a conversation about having anxiety with healthcare professionals, then I think we have an opportunity to support people at that early stage. Because if we support them at that stage, there is a high likelihood that we will prevent further issues, mental health related, fears about cancer coming back, and other issues down the line. So that is, if I had a magic wand, I would love for anxiety to be addressed and appropriate support. So this is not only about screening, but also providing appropriate support. There is no point in screening if the support is not going to be there. We need to ensure that we have capacity and evidence-based resources and support for people if they're expressing high levels of anxiety around the time of diagnosis.
Yes, when we talk about support, I was looking at this differently. Do you remotely think probably this distress or anxiety are in any way associated with the management process, what patients have to deal with when they are being managed for this disease? And do you think any core aspect of the intervention could actually deal with these conditions that you observed?
I'm sorry, what is this? Sorry, something has just appeared on my screen. Apologies for that. So here is the thing. Sorry if I get a bit distracted, but the thing that we often say is that the receiving cancer diagnosis is an incredibly distressing experience. And if people later on really worry a lot about cancer coming back, it is entirely normal. So one of the things that actually, in terms of the management side of things, is not to ignore the psychological impact. It sounds very, very sort of obvious, but there's so much focus around that time on the physical health of the individual, of making sure that they're getting the best treatment so that they survive this awful disease, there might be less attention towards more about their mental health related issues. And what happens is that later on, once the treatment finishes and hopefully everything is looking good for the person, there might be this tendency to want to move on among the people around that person, which may then actually interfere with expressing emotions. People may want to move on. Let's not talk about this cancer anymore. Let's just move on. And often what we see is that not being able to talk about one's fears throughout this experience is not helpful. It actually may make matters worse. So I don't know if I'm answering your question. Apologies that I was a bit distracted. Something randomly appeared on my screen at the time. But that's what I would say. I don't know if it answers your question, Paul.
Yes, I think you gave it a good stab, so I'll take that. I'll take that as a response. The one thing I'm also, when I saw your paper, it's connected to probably parallel subject I've been and trend that I've been looking at, which I think I would like your comments on, which is something that looks like integrating um, more than one responses together. For instance, oncology is used to be entirely radiotherapy and surgical. People are having cancer, so how do we deal with the cancer cells so that the cancer cells are hearts of the body? But we are now gradually seeing the introduction of, like you said, calling attention to the mental health impact of the disease and probably the interventions too on the patient to have this holistic approach. And I think we also see, if we go to infectious diseases, we're also seeing in the area of HIV, we are seeing mental health also being integrated to HIV. We're also seeing odd pairings of different diseases, and which makes me think, is this like the interesting phase? Are we in this phase is this the phase that we are in as far as healthcare is concerned? And what do you think? What is your perspective about this? Not just looking beyond what you are doing regarding your research finding, mental health, head and neck cancer in general, but seeing this as an interventional approach, not just from a research perspective.
What an interesting question. I think what we're seeing more and more is that obvious connection between our mental health and physical health being more and more better understood, and the need for therefore to make sure that we're addressing mental health as well as physical health outcomes. So we're coming to a point where we can talk more, I think, openly about holistic assessment when someone faces a life-threatening disease, the impact on themselves on a variety of ways, emotional ways, financial ways, the relationship, the social ways, how it impacts their relationship with others, with their co-workers, with their families. There's a huge array of impacts. And sometimes one aspect will come to the fore a lot more than the others. What I would say is that we need to also approach our holistic way of addressing things not as a one-time tick box exercise way, because things change. We're not static. The disease changes, the treatment changes from week to week, month to month, the impact will change. So what I would advocate is not only holistic assessment, but ongoing assessment and provision of support, depending on the needs of that individual. It shouldn't be a tick box exercise. And we should be able to support the individual throughout with evidence-based psychological support mechanisms.
Wow, that was impressive. Probably my second to last question for you would be comparing what the results from head and neck cancer with the trend with other types of cancers. So, how does this compare, and how is this unique?
You're breaking up, Paul. I can't hear you, I'm afraid. I'm sorry. You're breaking up.
I'll fix that. Can you hear me now?
Yes.
Oh, yes. Okay. So the question is this: compared, looking at those results from head and neck cancer with other forms of cancer or other conditions that you've looked at in the past or that you are aware of, how what is unique this time about this particular type of cancer, and what do you think is responsible for its uniqueness?
It's an interesting question. So in this paper, as I said, we were able to study a very large number of head and neck cancer patients. And the unique aspect of it is also it's a longitudinal study. What we often lack is these types of big data sets that followed up patients, participants over a period of time. We need those studies. They're expensive studies, but we need those studies. Now, I think, this study is only about head and neck cancer patients, but we know that there is a link often with anxiety and fears about cancer coming back, and maybe to a lesser degree with depression. So, what I would say is that it would not surprise me at all that a similar relationship would emerge if we had studied another type of cancer. I think this relationship, I would predict that it would appear again. But we don't often have these studies. That's why this study, Head and Neck 5000 study, is so unique.
Okay, thank you very much. So, last question is, what happens next? What is next for you? Are you taking this journey further, or how will you describe the next steps that is happening, or that would happen, or that should happen?
So, what we're currently doing with colleagues across the UK, we are doing a study called PETNEC 2 study. It is funded by National Institute of Health Research, NIHR, in the UK. It's a very large program grant. What we're trying to do is for head and neck cancer patients, trying to see if an alternative way of doing follow-up appointments would work as well as the normal way of doing things, follow-up appointments. And this new way of doing the follow-up appointments is what we call patient-initiated follow-ups. So we have developed programs where we worked with patients and healthcare professionals to develop material that would help head and neck cancer patients to identify early signs of recurrence and see if they're able to use those information to get in touch with the healthcare professionals when they're worried. So one of the things that we're also looking at, that's where I come in, is how this new way of following up patients working out in terms of impacting on people's fears about cancer coming back. So this is the study that currently I'm working on quite a bit. One of the things that we're working on in relation to this is how do we prepare digital health resources, whatever that might be, online resources or app-based resources, that would enable people also deal with their fears about cancer coming back better. But would people, if they have a lot of fears about cancer coming back, would they be actually engaging with material? Because it's scary. It's scary to think about cancer coming back. So those are the questions at the moment I'm trying to tackle with how do we prepare materials that engage people to help them with their fears about cancer coming back as a digital health resource? How do we create a patient-initiated follow-up that will help the patients, both in terms of their clinical appointments, clinical needs, but also psychological needs.
Those are really, really interesting research questions that you are hard to answer, and I strongly believe that the answers are very, very, very relevant. And I look forward to having this conversation with you when those papers are also out. So, any last words for me?
Any last words? I'm delighted that fears about cancer coming back through this paper is receiving attention, because we know that this is one of those top 5 concerns that cancer patients tell us that they're being affected by, and they're not getting support for it in a sufficient way. So my hope is that these patients will feel that they're being heard through our research, and then we'll put more and more spotlight on this issue so that they can get the support that they need.
That's really, really beautiful. So, I have a task for you, which is an attempt to get you to simplify the research for a general audience. So let me see if I can make this more fun for you. Gift, you are going to love this.
Okay.
Okay, come here, come here. So this is my little girl, and
Oh,
I want you to explain your research to her, the paper to her, and we'll see if she understood the paper. Go for it.
oh, this is a tough task. I'm Guzzy, by the way. I didn't catch your name. What's your name? Gets.
Gift, present, like present.
Gift. Oh,
Okay.
what a beautiful name. Hello, Gift. Well, so I do research with people who might be feeling a bit sick. They might be getting some sort of diagnosis from a doctor that their health is not working out really well. Okay. So, when we feel a bit unwell, we feel anxious, don't we? We feel anxious about why this is happening to us. What my research says is that if people feel anxious, we should really pay attention to that. We should see why they're feeling anxious, so that when they are getting better, and if they're really worried again that, oh, will this happen to me again? Will this sickness come back if we actually have a way of supporting them, because we dealt with their anxiety, with their worries. Does that make sense?
Answer that again. Okay, okay.
Yeah?
Yep.
You like it? You like my research?
Thank you so much. Thank you so. Oh, you want to tell her what you got?
Lovely
Okay,
to
tell her.
meet you, Gift.
So my summary of what like you were saying to me is that sometimes in medical health they have to see if people are feeling well, and then they like do the right tests on the medicine for them.
Yeah.
She got an idea. I'll take that.
Me too. Me too. This was a fantastic challenge, Paul. I loved it. Bye, Gift. Lovely to meet you.
It was really nice talking to you. So thank you so
Same, Paul.
much.
Same.